Hi, good to see everybody. We are going to be talking about sciatica today. This was my case report that I decided to do for a clinical rotation. So let's get started. So, what is sciatica? Sciatica is a compressed, inflamed nerve that is often caused by a lumbar disc herniation, spinal stenosis, piriformis syndrome. Those are a little bit of the main causes, but it could also result from trauma, pregnancy, prolonged sitting in certain positions, being overweight as well as that was one of my factors for the patient that I just saw in clinics. So you can see here in this picture, the sciatic nerve goes all the way from the lumbar spine all the way down the posterior chain of the lower extremity, all the way down to the toes. So whenever we have something like spinal stenosis or we have disc herniation, what happens is that that nerve gets compressed by the vertebrae and it causes pain. All the going and the it goes all the way down the posterior section of the lower extremity. So who is affected? This is actually a very common condition. About 40% of the population suffers from sciatica at some point in their lives. It is very common between the ages of 30 and 50, between men and women. Individuals with sedentary lifestyles or occupations that require prolonged sitting will be most affected, and also individuals with a high BMI. My patient in particular actually has several things that has triggered her sciatica. So she does have a lumbar disc herniation. She also has rheumatoid arthritis, which, as we know, affects the joints. And then we also have, she's also overweight. So this all these factors have just combined and really triggered her sciatic nerve. And I've just been working with her lately just to kind of help her get comfortable enough to be able to exercise because that's really what's going to help her long term with her sciatica. So, some risk factors that we may see, um, non-modifiable risk factors would be age, because naturally, as we age, we will see some degeneration with it throughout our bodies, and that includes our lumbar spine. So, particularly individuals over 40 years old will see these degenerative changes in their spine more than others. But some modifiable risk factors we would see is poor posture and prolonged sitting. Um, Due to poor posture, which, it's most likely too much anterior tilt of the pelvic, um, that would, of the pelvis, I'm sorry, that would be um, a modifiable risk factor because with the lumbar disc herniation, an anterior pelvic tilt is not going to help the disc herniation. So we actually want to promote posterior pelvic tilts in order to relieve that nerve that is being compressed in the lumbar spine. And this is it kind of goes hand in hand with prolonged sitting because when we are sitting, we tend to kind of rest in this um, anterior pelvic tilt. So it would trigger the sciatic nerve. And not only that, when we are sitting down, we actually put more pressure on that nerve because it runs through our piriformis and our glutes. So when we sit down, naturally those muscles will be putting pressure on the nerve. So when we sit down for too long, it tends to trigger that sciatic pain as well. So a little anatomy of the sciatica. The sciatic nerve is the largest nerve in the body. It is formed between the L4 and S3 nerve roots, and it runs through our posterior side of the lower extremity, from the glutes to the hamstrings, the gastroc, all the way down to our foot. So, sciatica occurs when the nerve is compressed or irritated, which can be caused by a herniated disc, bone spurs, spinal stenosis, muscle spasms, being overweight, being pregnant, anything that is increasing that lordotic posture. And then this compression actually disrupts the normal electrical impulses between the brain and the lower extremity, which then leads to pain, numbness, and tingling, and weakness of those posterior chain muscles. And the pain tends to be a sharp shooting pain that radiates from the lower back down to the leg and even the foot, which is, it's the main concern for our patients is that they feel like they're unable to stand and walk for long periods of time because of this sharp shooting pain that goes down their leg. So, some clinical manifestations we may see, we already talked about pain a little bit and how it can radiate down that nerve pathway, uh, numbness and tingling. So the numbness and tingling would be occurring again in those posterior chain muscles, especially when they are walking or standing for a long period of time. In severe cases, any standing and walking, no matter how long it is, triggers the sciatica. And then we would in turn see muscle weakness as well of those posterior chains. So it would affect our gait pattern, lifting the foot, even walking on toes or your heels, or like I said, difficulty standing. We would also see loss of reflexes of the Achilles reflex and the patellar reflex because those again are in the lower extremity, which is affected by the sciatic nerve. And here is an example of the Achilles reflex and the patellar reflex. I'm sure you've gone to the doctor and have at least seen one of these at some point in your life. The patellar more than the Achilles, I would say. So impact on function. We use our lower extremities for anything. Not just like walking and standing or running. Not It's also like when we sit, when we sit, when we lay down, like if our sciatic nerve is aggravated, we cannot do any of these actions for too long. So walking is made difficult because again, there's pain and weakness in the leg. If you take a look at this picture here on the side, all these red spots going down the leg are common pain um, that you will see going down the leg. So as you can see down here at the bottom, we step on the dorsum of the foot or sorry, the base of our foot for a lot. If we step on it for a while, so, if we're experiencing pain at the bottom of our foot, it's just, we're going to be aggravated with no matter what we're doing, standing as well, going up the stairs. Not only will we feel pain, but we also may experience muscle weakness, which would actually make going up and down the stairs incredibly difficult. And same thing with lifting objects. We need that strength in our posterior muscles to be able to lift objects efficiently, but also safely. We also don't want to be hurting our spine any further if we can't even be lifting objects correctly. So some physical therapy interventions that we may see in the clinic is stretching and strengthening, because again, we want to improve the flexibility and the strength in our lower extremities. It's not just the posterior chain, but also the anterior chain. We want to treat the leg as a whole, so the stretching and strengthening. Postural training, like I said, we want to promote a posterior pelvic tilt in order to decompress that nerve that comes out of the lumbar spine. Pain management. Pain management is huge for our patients because it is because of this pain that their function is impaired throughout the day. So we need to teach them about pain management, using heat, using ice, even using nerve guides. As I'm about to cover the nerve flossing. Um, so gait training again. We may see some gait deviations depending on the patient's pain. For example, with my patient in particular, I saw a Trendelenburg in her hip because she was, of course, trying not to put too much weight on her left lower extremity. Um, and then she also had a little bit of an anterior trunk lean as well. We also focused on nerve flossing. Nerve flossing can be pretty, it can be pretty relieving for a patient if they are feeling extreme pain. I always recommend it. I walk them through it during our clinic. I show them exactly how to do it. And I always say, if you're at home and you're experiencing some pain, just go ahead and try this. Hopefully, it'll relieve some of the pain. As you can see, here are some of the interventions I just spoke about, and all of these interventions I personally used on this patient. So we have here our posterior pelvic tilts. I instructed the patient to be on a bed or on the floor, and to again focus on flattening out that back so that we could promote a posterior pelvic tilt. Then down here we have a piriformis stretch that we would use. The nerve glides in supine in particular I would use. And then here in the center is the venom. Venom is the modality that I would often use in the clinic. This provides heat and percussion therapy. So it would actually be a huge pain reliever for the patient before or after treatment, depending on our day. But typically, I'd actually like to give them the venom prior to treatment. And then over here we have some exercises we would do. We would do some side-lying clams with a resistance band. We would also do supine clams as well. We also have bridges here. And if we like to make the bridges a little bit more challenging, we could also use a resistance band, or I would also use some ankle weights that they could put on their hips just for a little extra resistance when they would come up into full hip extension. And here's a picture of our Trendelenburg gait that my patient in particular was displaying because, again, she just did not want to put too much weight on that left lower extremity. So a little discussion about my patient in particular. During her initial evaluation, we acquired our patient history. which again, she has a disc herniation in her lumbar spine. She has RA, which, as we know, is also early onset. So this actually could have been the first domino to fall in effect that would eventually lead to a sciatica. Uh, then we did an observation and postural assessment, which we found the Trendelenburg gait. She also has a lordotic posture, and she also has a little bit of genu valgum. So the lordotic posture is mostly due to her being overweight. Naturally, that extra weight and the anterior side will bring the lumbar spine into a little bit of a lordotic posture, which would then compress the nerve. And then it's because of the RA that she has, she's probably experiencing some genu valgum, which again affects your gait, it affects your knees and your hip. Um, and then we also did some palpitations along the nerve path, looking for any tenderness or swelling. We are looking for spasms and tightness, which she did display tightness in her QL muscle, the quadratus lumborum. She also had some tightness in her glutes, her piriformis, and some of her gastroc as well. And we also saw some tenderness and swelling on her first visit. So our prognosis for this case, it is a moderate case. Um, and this is due to no significant motor weakness, no significant loss of reflexes, and we should hopefully see improvements within 6 to 12 weeks. So my patient, although she finds it very difficult to do basic tasks like showering, going to the restroom, walking. She ultimately could do it. It was just incredibly difficult for her. Um, so this is why this is a moderate case, because again, she is ultimately able to walk, um, but obviously very slowly. And immediately after our first session together, she did feel improvement. She said that she was able to walk with a little more ease. Obviously, she was still in a lot of pain, but she did notice an immediate difference. And then I would say she's probably had about 8 sessions at this point, and she continues to be impressed with the mobility that she has now. She may not have it 100% of the time, but she was able to lift her leg with a little more ease when we did our nerve glides, and she was incredibly happy about that. And she was also incredibly happy about being able to shower with a little bit more ease as well. So, interventions for different phases. In the acute phase, we want to focus a lot on pain control, postural education, and gentle range of motion exercises. With my patient, with pain control, obviously we like to put on the venom on her to promote that heat and the percussion that would relax her muscles and get her ready for treatment. We also focused a lot on postural education, promoting that posterior pelvic tilt. For the subacute phase, we moved on to stretching and strengthening, any activity modifications, and manual therapy. For my patient in particular, we started stretching the hamstrings, her quads, and we were strengthening her hamstrings and her glutes as well. Um, and then we also did a lot of manual therapy with her. We did trigger point release. We did a little bit of lumbar mobility. And then we also did soft tissue immobilization as well for the chronic phase. Advanced strengthening exercises, so we can turn that supine stretch into a standing stretch. Turn it from a static stretch to more of a dynamic stretching. Do a little bit more weights with the strengthening, going from gravity eliminated strengthening exercises to gravity strengthening exercise. Strengthening exercise against gravity. Uh, and then we also do a little bit more postural training and aerobic conditioning. So and the clinic particularly, we like to get them on our stationary bike to get that a little bit of that aerobic endurance in them. We like to do maybe about just 10 minutes on the bike. So a little reflection for my case. So looking back at this case, I loved to be able to see the change in my patient. She came in very defeated and she was just very vulnerable. But then immediately after our first session, you could see a little bit of a spark in her eye, like wow, like I'm like already feeling so much better. And obviously, like by the next time around, she was already kind of like, oh, it's come back, like I'm starting to feel the pain again, but it's only natural, especially with my case because since she is overweight, that's really our long-term goal, to lose that weight to so that we can improve her posture even further and hopefully decompress that nerve um, that's being compressed in her lumbar spine. So a lot of the things that I like to do with them that really helped my patient was, again, manual therapy, the trigger point releases, the joint mobilizations of the lumbar spine, the therapeutic exercises, which was the strengthening and the stretching, and lumbar gapping. Lumbar gapping is right here on the bottom right, where you just want to create some of that space within the lumbar spine. So just so again, decompress the nerve. But overall, it was a great experience to be able to see the improvement with this patient. I really connected with this patient and she connected with me as well. So it was just overall really great, really grateful. All right. Thank you so much for tuning in. I'll see you guys around.